Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning into the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare delivery, technology, and, of course, regulatory compliance. I'm really pleased. My guest today is Matt Fisher. I've known for quite some time. Matt is an attorney and general counsel for Carium, which is a telehealth platform company. Matt is responsible for all legal functions in the company and helps to ensure that operations meet the requirements of relevant healthcare laws and regulations. For over 10 years, he has been considered truly a thought leader at the intersection of healthcare and law through his blog posts and participation on other social media platforms. So, Matt, good morning and welcome to the Tate Chronicles.
Jim, thanks for having me on. It's always great to be able to chat with you, and thank you for the very kind introduction.
You're welcome. We've got a really timely subject to kind of go over today, and I'm looking forward to hearing your thoughts. We're really witnessing some new channels of healthcare delivery, and I'm looking forward to really hearing your thoughts on this evolution. Before we go to the details, tell me a little bit about Carium. What does Carium do? Who are the clients? Is it a software platform? What's going on over at Carium?
Yeah, so Carium's kind of a telehealth platform that operates as a software as a service. So we work really with kind of most types of healthcare delivery organizations, whether it be large health systems or physician practices, or even some connected, into the non-traditional pieces of the healthcare industry. And what the platform does is it's, a really amazing patient engagement and care coordination platform where, kind of the traditional video visit is embedded into it, but really the best components are the ability to hook in and connect various devices so patients can have data flowing into the platform while they're at home, which kind of naturally supports a remote patient monitoring or any of the other at-home monitoring services like chronic care management or transition care management. And then, as I said, feeds that all into the app where you have, a dashboard that presents and analyzes the information for the care team. There's also the ability for the care team to push out messaging and information and surveys and other kind of pieces to keep patients, going in a positive direction. And, it really facilitates, that ability to interact with patients where they're at and, at their home. And we've been seeing some great feedback, especially over the past year, both from care teams saying, that the ease of use is, a very great benefit for them because it helps, make them more efficient. And then then from the patient perspective, it's, I think one of the most impactful statements that we've seen is, someone said that they didn't feel alone, especially during the COVID pandemic when so many people were having to stay at home, and especially if you're kind of thinking about this type of patient population where they probably have various comorbidities, and we're trying to isolate as much as possible or quarantine and trying to stay healthy, that ability to feel connected and to be able to interact with their care team, people found really invaluable.
Matt, one of the things that really has brought, for lack of a better word, telehealth to the forefront has been what's really the whole COVID pandemic. And so to be able to communicate with patients and provide healthcare through these electronic channels has really escalated the adoption of a lot of the technologies. And of course, with that, a lot of challenges and opportunities. But let's touch on the regulatory aspects of some things. I know that almost every medical practice had to go out and immediately start doing some type of telehealth to take care of their patients. And part of that national emergency allowed the relaxation of some HIPAA enforcement. What's the status of that? Is it going to be rolled back? Where are we in the whole relaxation of HIPAA enforcement?
Yeah, when looking at that relaxation and, kind of, I think as the government would phrase it, the enforcement discretion. So basically saying we're not going to penalize you if you're kind of making good faith efforts, and even with that you're not able to comply. But kind of as we're talking, here in late February 2021, the public health emergency still exists and is still in place. So all of that relaxation or discretion, exercise of discretion still exists, and technically that still means you can use non-compliant services. But as things, even with COVID still being a rampant issue within the world and within the industry, arguably things have stabilized a little bit. And at least from my perspective, there is certainly that opportunity and really the necessity to make sure that appropriate systems are being put into place and being utilized, because to the other part of your question, Jim, this enforcement discretion is not going to last forever. I feel like I saw maybe earlier in 2021 that the public health emergency will remain in place potentially through the end of this year. Although I think more recently CMS, or maybe it was HHS, said, we're going to try to give you at least, you meaning the healthcare industry, at least 60 days advance notice of the PHE ending. So, give you that 60-day grace period to, get your compliance house back in order. But again, I think the more that can be done up front and the more that can be done right now to make sure, one, you remember exactly what all the requirements of the various regulations, governing operation are, but also, along with that refresher to, realign and readjust operations, really just provide a lot of benefit going forward. Because it's much better to establish a solid workflow and keep building upon it, as opposed to continually having to shift and go in many different directions.
One of the things that had really kept a damper on the acceptance of telehealth, and by specifically not remote patient monitoring, but just telehealth encounters, is that for providers, the reimbursement was much higher for face-to-face encounters versus a telehealth encounter. And so part of the emergency was declaration, involved some changes of some rules and regulations so that there was parity for reimbursement between telehealth and face-to-face encounters. That was a giant thing. Do you think that's going to continue?
Yeah, that piece, the reimbursement parity is certainly one that's up for major debate. I believe a few states have taken legislative action to permanently encode that parity around reimbursement, which, as I think you're right, is a major driver for the expansion and utilization of telehealth in all forms. Because if money unfortunately still does talk, and if you're not being paid to do something, then there's not really any incentive to keep using it. At the federal level, with CMS seems to have taken about as much action as it feels it can do with the 2021 physician fee schedule for Medicare. And now at this point, you really need to see legislative action from Congress. I believe that there's at least one major telehealth-focused bill pending before Congress, and if I recall the details, it's really part of that. It calls for a study of the fiscal impact of the expansion of telehealth reimbursement through the pandemic, because unfortunately, one of the arguments against extensive reimbursement for telehealth was that you can access it so much more easily, that there's this fear that hasn't necessarily been proven out with evidence of increased utilization, which means increased charges and you're draining the Medicare fund more quickly. However, it'd be great to use real evidence that could likely be examined from the past year's use of utilization to see what the actual levels are, and I suspect that it will likely be found that there's inappropriate shifting of care, and I think you'll notice some efficiencies. And then one of the other arguments against payment parity that I've seen raised, and I believe this is usually coming from the insurance side, is that the overhead of running telehealth is not the same. So there's not necessarily the same justification for a co-equal level of reimbursement because the expense to the practice or the facility of operating the telehealth isn't the same. So there's an arguable justification to have the reimbursement a little bit lower. There are, in talking about reimbursement in that perspective, you're really talking about, I think from my perspective, telemedicine, where, kind of as you were suggesting, it's shifting what had previously been an in-person visit into the virtual world. If you're looking more at remote patient monitoring or some of these other forms of telehealth that, arguably are more, kind of more supplementary or more extensions of care, then reimbursement has actually been around for at least a few years and certainly predates the pandemic. If you're looking from a fee-for-service perspective, it can arguably really be additional revenue for a practice because it's allowing for broader, more in-depth engagement with your patient population and being able to have payment follow and recognition of those additional services that are being provided. And then also on top of all of it is, considering how this impacts the continuing shift of the industry into value-based care. So if you're being paid, arguably on a capitated or similar type arrangement, or, you're getting a bundle payment, then you're trying to figure out how to keep your population as healthy as possible so that as efficiently as possible so you can keep more of those dollars. And that's certainly, I believe has a solid role for telehealth in all forms, because the more that you can interact and the more data that you can gather from people while they're in their normal daily lives, the easier it's going to be to have positive health outcomes.
One of the things, Matt, that we saw 11 months ago, is probably in the third week of March of 2020, when the schools and colleges shut down, all elective surgeries and admissions to hospitals were canceled. Providers were not seeing patients in their office. Patients wouldn't go to an office. And so the only way to provide a lot of healthcare at that time, or at least communication between providers and their patients, had to be decided in a matter really of days, maybe a week or two at the most. And so a practice might spend months and months and months selecting an EHR, but in the case of what happened with the acute need in March of 2020, they just grabbed any software package, many of which were not clinically based, and started using them. And there was processes that had to be developed, how to schedule patients, many patients who had never had a telehealth encounter, and just so many lessons that had to be learned. And it seemed like within about, 3 or 4 months, that kind of settled down somewhat. But there were definitely some best practices that have emerged. And I guess one of them is that their telehealth package from the patient side must be intuitive to use and doesn't require a great deal of technical knowledge to make sure the camera's on, to make sure the audio's at a proper level, things like that, or to be able to exchange files or have multiple people in an encounter, things like that. So what were maybe some of the best practices or lessons learned that you've seen providers be able to pull off in terms of process and functionality?
Yeah, I think you probably hit on most of the best practices, but kind of, at least from my perspective, boiling down, I think a lot of what you're highlighting, and I think a lot of what the reports are suggesting is you got to make it easy. You don't want to be throwing up barriers and having people, whether it be the patients or the physicians or other clinicians themselves, having to jump through all these different hoops to get on. You want it to be simple, and I really liked your description of intuitive to utilize. It's, you've got so many different forms of technology like that in your daily life where you just press one button and you're up and going. So you want to try and have the telehealth solution mimic that as much as possible and not interfere. So ultimately, I think that is the key lesson to take away is you've got to be able to fit it in and make it really simple and not difficult at all to use, which again, I think you had summarized it perfectly. And I do suspect that a lot of people are seeing that lesson, because it's, whether the patients are complaining or the physicians are complaining, the complaints come up when it's not clear how you actually go about, doing it. And then, also connected to that ease of use, you want something that's going to integrate with your other systems. You can't be creating more silos. I think the discussion of silos and breaking down those silos has been a common refrain within healthcare for the past number of years, and you really don't want to unintentionally throw up more barriers through telehealth. So I think the solutions that are working best are ones that integrate into existing systems, or kind of operate as platforms. And the platform aspect, again, I think goes to ease of use, where you're able to interconnect many different components and make it, kind of one-stop shopping from that perspective. So I really think that's the direction that healthcare technology is moving towards, is that platform-based approach, where you don't necessarily have one solution, but maybe you have one solution that's able to bring in and connect all these different components, so that way you only have to go to that one place to be able to find everything that you need.
One thing that differentiated to me a telehealth solution, and again, talking about telehealth encounters, we'll get to remote patient monitoring in just a minute, Matt, but the off-the-shelf technology, non-clinically based, really had no way to document clinical information. You're just seeing somebody on the screen. Maybe you're talking to somebody on the screen. Maybe you can chat a little bit by text. And so in what ways have you seen that, and we'll use Carium as an example, during a telehealth encounter, where is the documentation actually taking place? Is it in a standalone EHR? Is there some type of interface? Where's the documentation?
Yeah, no. So, using Carium, we can integrate into the EMR. So there is, we have that capability to embed and also have the documentation, whether, go into the EMR or be within the Carium platform itself. And then the Carium platform can also pull in the data from either the EMR or, as I mentioned, kind of the key perspective is, from the devices that the patient themselves are using. So it's, getting that comprehensive picture. But it kind of goes back to that platform perspective that I was just mentioning, that, regardless of where we're going to have the data reside, you want to have it all in one place. You don't want to have to be clicking through multiple different screens, because that's going to impede the workflow and it's going to impede the ability to provide good care. So I think the tools that are going to be successful in the long run are the ones that are able to create that comprehensive and cohesive picture of the patient. So it's, I see that's kind of where the separation and the distinctions are going to start occurring, because again, it all goes back to that ease of use and making it simple that we were talking about a few minutes ago.
Boy, before we totally run out of time, we only have about 10 more minutes, I want to move on to remote patient monitoring. To me, RPM, as it's called, shows fantastic potential for healthcare delivery to allow us to do things that we've never done before in terms of healthcare. There's some real promise here. Is it being hampered in any way by reimbursement? Or first, if you would just give us a maybe generic definition of what remote patient monitoring is.
Sure. So kind of from the broadest strokes, remote patient monitoring is the establishment of, kind of care management of a patient through some level of daily readings about a particular condition that are, I guess, ostensibly automatically recorded and transmitted through a connected device that can then be analyzed and interpreted by an appropriate member of the care team. That also results in some degree of consultation interaction with the patient, and then also enables updating to and refinement of the care plan. So that kind of sounded like even that sounded like a fairly technical definition, but I think at its core, RPM is keeping track of and keeping tabs on a patient in their own home in their daily life, and then having that data pushed back to their physician or other clinicians so they can understand what's happening and be able to talk with the patient about how those readings and what those activities are doing to their health in real life.
Well, we're already seeing where, for example, people who have diabetes have electronic diabetic devices that give their blood sugar levels, and folks with maybe heart failure weigh themselves once or twice a day. People with hypertension check their blood pressure regularly. And so if those, whether they're analog or digital recordings, can become electronic and digital and sent to a place where they're being monitored, that's like, the old saying, a stitch in time saves nine.
No, I think that's exactly right. And I think one of the criticisms that currently exists about how CMS for Medicare at least is interpreting RPM is, kind of one of the clarifications that came out in the most recent physician fee schedule is that that information that you were just mentioning, whether it be a blood pressure or a weight on a scale, CMS is requiring that to be automatically transmitted by the device to the data repository. They're not allowing the manual recording of the information, which, I think at this point might be somewhat of an issue because, maybe the device didn't work for some reason, and now can you not include that reading, or how do you go about addressing that issue, or it kind of puts a burden on the patients who maybe aren't as tech savvy with some of the solutions that are out there. So it's I know there was a number of comments submitted to the physician fee schedule around that particular issue. And also the number of recordings per month that are going to be needed, because maybe not every condition requires the same degree of day-to-day monitoring. So it's kind of trying to refine it and understand the nuances between the different types of conditions that are being managed through RPM.
If there's a practice maybe that specializes in diabetic care, and they have devices at patients' home that send that information in, you really want some type of capability to generate or build rules to generate alerts so somebody can know to do some type of intervention. Where are we in that stage of the clinical decision rules?
I think, there are certainly, kind of evidence-based guidelines, whether you're talking about diabetes or other conditions, of what should be concerning. And the systems that are premised upon those best practices certainly have those built in. It's like, I know within the Carium platform, it's, we can have kind of standardized parameters where an alert will be flagged for the care team member, within their dashboard if a reading is out of range, or, some of these practices have their own measures where they want to get the alert, so that can be customizable as well. But at the same time, there's always that concern of you don't want to create alert fatigue, since that is a very real issue with all these new data sources that are coming in. So it's I think being very deliberate and considerate in figuring out when and how those kind of flags and alerts are created. But again, it's kind of all goes back to appropriate evidence-based medicine. And then kind of the other piece of it is, and this is why you want to be very, I think, careful in terms of how those flags are created. Is you don't want to be either having them appear too frequently or too infrequently and potentially miss an issue, because then probably most likely for the clinician side, you don't want to be creating unnecessary potential risk and liability where someone would say, oh, you should have seen this at this particular time, and because you didn't, a bad outcome occurred. So I think all those pieces are kind of being worked out, but at the same time are probably more advanced than might readily be kind of understood or ascertained. That's really true. And then also just the process. Most medical practices are not used to having real-time dynamic electronic data feeds coming in. And so the processes that need to be developed, the staff
involved in those kind of things. So it will be a step up. Matt, I can't believe it, but we're almost totally out of time here. I want you to commit to come back and talk again soon, because I want to be able to talk much more about remote patient monitoring. We didn't even really mention chronic care management, which is a big topic. So I'm hoping you'll come back and speak with us again soon.
Yeah, no, I'm always happy to come back, and certainly always happy to talk about these issues, because I think, Jim, as you said up top, it's, they're very important. They're growing areas of need within the healthcare industry, and we're only going to see increased utilization and importance when it comes to preventative medicine and overall health for the patient, because we always have to remember the patient is at the center of everything, and everything that we're doing within healthcare should be for the purpose of promoting the best interests of the patient.
I like to tell our audience you can learn more about Carium and their service at Carium, Carium.com, and a lot of information, really educational there on reimbursement. They've got some good blogs. And Matt is a colleague who has a very active podcast at healthcarenowradio.com called Healthcare Du Jour. Thanks for joining us on this episode of the Tate Chronicles. I offer a special salute to my guest today, Matt Fisher of Carium. Matt, thanks for coming aboard today.
Thank you very much. It was great to chat, and great to be able to dive into some of these issues.
Great. You can find more information on this show's program page at healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.